My name is Claudiu Lungu, and I'm a professor of environmental health sciences, specialized in occupational hygiene and occupational exposure assessment at UAB School of Public Health. One of my area of expertise is respiratory protection. So I've put together this material on face covering in the context of protection against infection with COVID-19. I borrowed this graphic representation from my friend Dr. Lisa Brosseau at University of Minnesota. It shows how the viruses are transmitted from a source to a receiver or receptor. You can see that the pathway of transmission between the source and the receiver is filled by particles of various dimensions. This is because we have individual viruses, which are very small, 20 to 500 nanometers, but also virus agglomerates, water vapors, and various other particulate matter on which viruses can adhere. These are much larger, ranging from a few micrometers to hundreds of micrometers. When coughing or sneezing, large droplets are formed potentially containing viruses. These droplets will travel for short distances in air and could contaminate a person at close proximity. Additionally, droplets may contaminate surfaces and could contaminate a person through hand, mouth, or nose venue. Small particles containing viruses or the viruses themselves could be airborne for long periods of time, tens of minutes or even more, and travel long distances in a close, non-ventilated environment. Although recognized only later into the pandemic by CDC, this transmission mechanism could be more efficient and probably responsible for a large portion of personal contamination. Let's talk about respiratory protection and what are the characteristics of a respirator or mask we should look at. There are three main elements we should take into account when choosing a face covering protector. The first one is the filtration efficiency, which means the percentage of incoming particles which are retained. The second one is the fit, how close to the face is the respirator or mask. The third one is the breathing resistance, how difficult the mask does make to breathe. When looking at these elements, the N95 family of respirators is the champion. It retains 95% of the most penetrating aerosols, it fits close to the face, and for healthcare workers and other worker categories, there are fit tests to assess the degree of fitting. It also has a low resistance, making it relatively easy to breathe through the respirator. Even non-fit tested respirators provide a decent protection to the wearer, much better than any mask. The surgical or medical masks are made of multi-layer synthetic material which has good efficiency against larger particles and lower efficiency against small particles or aerosol. It fits much more loosely on the face, so particles transporting viruses could enter the respiratory tract by avoiding the filtering media. It has low resistance, so breathing is not difficult. They are meant to be disposable, so mask needs to be replaced after sustained use, such as talking for longer period of time. Cloth face coverings can be made of one or multiple layers of woven cotton or synthetic material. In general, they have inefficient filtering capabilities, but could retain some of the outgoing particles when coughing or sneezing. They can be washed, and this increases their utility life. They are less likely to protect the wearer against virus contamination. This table, which I also borrowed from Dr. Brosseau, shows the estimated time to infectious dose for an uninfected person when both the source and the receiver wear a certain type of face covering or respiratory protection. For example, when both the source and the receiver where a surgical mask, the estimated time to infectious dose is 1 hour. This time increases to 25 hours when both are wearing N95 fit-tested respirators, and decreases to 25 minutes when both are wearing cloth coverings. This estimation assumes that both the source and the receiver are not observing any set distancing. Choosing a certain mask or respirator to protect against contamination with the COVID-19 causing virus depends on the type of work one is conducting and the time which a person spends in the proximity of other people. Healthcare providers should always wear an N95 type fit-tested respirator, which should be single-use. Daycare, supermarket, restaurant workers, and others should wear a non-fit-tested N95 type respirator and replacing it at least daily. Same recommendation would be for any person working in a crowded environment such as retail, crowded offices, entertainment industry, etc. This table shows the type of work and instances in which an N95 type respirator is recommended. For workplaces and instances in which a 3 feet distance can be kept, a surgical mask is recommended. Students, office workers, and other indoor workers, when a 3 feet distance can be kept, should wear a surgical mask. The same recommendation is for the general public working indoors or walking in crowded spaces. It is also more reasonable to assume that these categories will more likely accept to wear a surgical mask than an N95 type respirator. This table shows the instances and workplaces where a surgical mask should be worn. As discussed before, because of the low filtration efficiency and high breathing resistance, cloth face covering should be used only when other types of masks and respirators are not available. Once in a while, we see people wearing double or multiple masks. Double masking should be considered when a single surgical mask is loose, and doubling the mask will ensure more and tighter covering. In the case of closed face covering, double masking is not recommended because it will increase the breathing resistance and the moisture content, making breathing difficult. Masks with exhalation valves are not recommended because these are intended to protect only the wearer, and in case of viral infection, will release the viruses to the environment. Face shields, although quite popular, do not provide any protection to the wearer and allow viruses to propagate from the source to the receiver. Although masks and respirators are very important in prevention of the infection with COVID-19, it is essential to remember that personal protective equipment represents the last resort in disease control. This table exemplifies the hierarchy of disease control in which limiting the number of sources or time spent in shared spaces has the highest priority. Obviously, vaccination is the first measure to take in order to limit the number of sources. The second step is to limit movement of infectious particles through increased distance between source and receiver and ventilating indoor spaces. And only the last measure of control is to wear masks and respirators.